patients will come in and they'll have droop and they'll say, oh yeah, I just want some implants, and they go like this. Well, the implant doesn't do that. The bottom line is, and I tell patients this, if you need a lift, you need a lift. There's no way to get around that.
Behind the mask. The more you know, the better you look. Behind the mask.
Hi, it's Dr. William. Welcome to another episode of Behind the Mask. Tonight, I'm going to be talking to you about breast lift. And it's difficult to show breast lifting in real life because the problems with showing the surgeries and showing the nipple and the areola. What I'm going to do today is it's going to be a little bit of arts and crafts. I'm going to be using some of these felt pieces to show you what a lift is and how we do it. Now, the reason I've drawn this line is this line here represents what we call the IMF. The IMF is the inframammary fold. That's just simply the crease that's under your breast. In a typical breast that doesn't have any droop, that doesn't need a lift, that doesn't need anything, it looks something like this, where you have the nipple and the areola are well above the fold. That's a normal breast. It doesn't need a lift. The nipple's at the correct height and the breast has a normal shape. The breast can undergo a lot of changes, and this is very different for everyone. Some people can have multiple children and their breasts are still in this shape and still look fine and they don't need any lift. Other patients can develop lift either through weight loss or after having children or just through aging, for any of those reasons, but to different degrees. So you can have a situation where your nipple and your areola is kind of at this line. So your breast has dropped a little bit, but not something that's really very dramatic. You can have somebody that then will droop a little bit more, where the nipple and the areola now come down further down from the relationship with this breast fold. Or you can have even more where patients have a nipple and areola that are actually pointing down to the ground. The general rule is that the more droop you have to your breast, the bigger your scar pattern. So if you call that 1, 2, and 3, if you're a 3 or you're a 2, you're going to need a bigger operation. So what are the types of scar patterns that you have? Let's say this person here who has a normal breast, nothing is hanging below the crease or below the IMF, and that patient wants to change her breasts, then all we do is a simple breast augmentation. That would be just a regular breast augmentation. That's just adding an implant to your breast. Your incision is going to be just in the fold right underneath your breast. And that's the only incision that you'll have. That's the only scar that you'll have. When you have more droop to your breast, you'll need a different operation. If you're somebody who has this number 1 configuration, where your nipple and your areola are just a little bit lower than they should be, just maybe at the fold or slightly below the fold, then we can do an operation that's called a concentric mastopexy. And I'll tell you why it's called concentric, because it's going around the nipple and the areola. What I do is I still make an incision underneath the breast in order to put the implant in, but the other incision, in order to do this lift, goes around the areola. As you move on to either 2 or 3 grade of ptosis or amount of droop, you have more droop, then you're going to have a completely different scar pattern, and it's a scar pattern that nobody really wants. But the small incision around the areola is just not powerful enough to be able to move an areola, say from here, and a nipple from here, all the way back up to the correct position. You're going to need a bigger incision pattern because you need a more powerful operation. Let's call this 0 here, normal breast. That would be 0. That's no lifting. That's just a breast augmentation. This would be for patients in the number 1 configuration where we don't have to do such a big lift. It's really more of a nipple areolar repositioning. You can just have a concentric mastopexy with an incision around your areola. If you start getting into group 2 or 3, where you really need to bring your nipple and your areola a long way up, you're going to get a bigger scar pattern. Remember, the more droop, the bigger the scar pattern. In this situation, where the scar goes, is it goes around the areola again, and then you'll get a vertical incision. That's why we call this type of lift a circumvertical, because we're going circumferentially around the areola, and then adding that vertical line is a circumvertical lift. And the incision also goes underneath your breast. This is the so-called anchor or inverted T incision pattern. These are the 3 scar patterns for different styles of either no lift or a lift, depending on how much droop you have. That's sort of the plan. Now, in order to demonstrate these types of things, I'm going to use these little felt pieces here. How do we actually do a concentric mastopexy? Well, what I've done here is I've just used these little things to show you. This is your nipple and your areola. Now, we never take the nipple and the areola off and move them. That's a kind of pretty common myth or misconception, rather. People think that, oh, your nipple is here and you have this very droopy breast. We're just going to take your nipple off and move it. You don't do that, because you would kill the nipple and the areola. There would be no blood supply. The main thing that we have to do when we do a lift and we're repositioning the nipple and the areola up to a higher position, we have to preserve blood supply to the nipple and the areola. We can't just simply remove it and stick it back on and reposition it. Technically you can, that's a free nipple graft, but that doesn't look good, and it's a disaster. What we do, if we're in this stage 1 type breast, or what we call a grade 1, is we make an incision that goes on the outside, and then we make an incision that goes around the areola. But that intervening skin that's shown here in white, we actually remove that skin. And by doing that, we actually make it a little bit asymmetric, so it looks more like this in real life. And we make this incision on the outside and get rid of that skin. So this white tissue here is just breast, and that's fat and breast tissue, but there's no skin there. And some surgeons use this. This is actually how we were taught. And this is a special suture that actually is made of Gore-Tex, and it slides really nicely. And so what we do, in order to reposition the areola, it's still attached to you. That's where it's getting the blood supply from. But in order to reposition it, we tighten this up, and that will move the nipple and the areola up just a centimeter or 2 to that higher location. We do that with an implant underneath. And so I'm just going to kind of show you what that would look like. And so then we pull this, and that will reposition the nipple and the areola. But now you have a fuller, better shape to your breast, because it's being done over the implant that has been put in previously. And it's wonderful, and it has good long-term results and can give you a nice shape to your breast with relatively minimal scarring. But when patients have more droop, they're going to need a more powerful operation. That's why when you do this operation, a concentric mastopexy, it's somewhat limited in power. We can't do it for somebody that has grade 3 droop, where your nipple is hanging down looking to the floor, because we would have to take out so much skin, and then we would try to pull it together, and eventually your body would just stretch that out. And there's pictures in textbooks of these horrible scars where patients had a concentric mastopexy, where they really needed a full circumvertical mastopexy, a full lift, in order to really move the nipple and the areola higher. And what happens is the scar stretches and you get these horrible scarring. So It's a wonderful operation. I do it frequently for patients, but the right patient. They have to have a relatively small amount of droop to their breast. This is going to be another patient. This is going to be a patient with either 2 or 3 amount of droop. And so they're going to have more droop. You need to use this bigger operation. The real power of this operation is this vertical line here. And this vertical incision, which nobody wants, which actually ends up healing the best out of all the scars, but that vertical incision allows for a completely different operation. And that's why this operation is so powerful, to be able to lift a breast that is more droopy. The way I do it, I build the breast over a temporary implant. It's not really the final implant, it's a sizer, so it's a temporary implant. And once I have everything kind of designed, then I remove that sizer and I put the final implant in. Everybody focus on the number and the size and all this. I don't really think of it that way. This is just a tool for us. I use the implant for the benefit of the shape of the breast. For most patients who are undergoing a lift, they're also getting an implant. You can see now the power of this vertical scar is it allows me to shape the breast over top of the implant. And so your breast now has a fuller, rounder appearance to it. And because we have done the lift, your nipple and your areola not only have a better position, but your whole breast is much more perky and full and has a better shape to it and a better look to it. And then you'll see this extra tissue here. We cut those off and we discard them. And that gets rid of that tissue that is hanging down and contributing to your droopy look. We don't want that tissue. It's not benefiting you. It can re-droop as well. So we want to get rid of that tissue. I can't get rid of any tissue when I do this other than some of that intervened skin bridge, but I can't really remove that droopy tissue. We can never make somebody that has a breast lift with an implant look exactly the same as somebody who only gets a breast augmentation. They don't have any droop to their breast. We can never make them look quite the same. You can imagine if I don't have a very big implant, I have an undersized implant for that patient's breast. When I go to do the coning, there's nothing there to support it. So if the implant is too small, you still end up with kind of a anemic looking breast. Whereas if you use the correct size implant that hand in gloves fits your breast perfectly, gets all the maximum space that you can out of your breast, and then we re-drape everything and rebuild the breast over that implant, we get a really nice pretty shape. The same thing can happen if you're using an oversized implant. Then what happens is we can't get the really nice perfect shape that we're looking for, and we can't bring this in to get a nice conical perky shape because the implant is too big. So we're not able to do that, and we're not able to bring those two pillars together, and then you end up with a breast that's bigger, but it doesn't look as well. One of the consequences of using a concentric mastopexy is that there's some breast flattening. Now, if we don't take out too much skin, and we're using this operation in the appropriate patient, in a grade 1 patient, then we can still get a nice result, and the flattening is really not that apparent. But if we start to push the boundaries, if someone comes in and says, I know I need a lift, I think I probably need the vertical scar, but I don't want that. I only want the concentric one that goes around the areola, which is very common. Makes sense. People want to have less scarring, obviously. But the problem is when you really try to push this concentric mastopexy past that 1 or 2 centimeter mark, then what happens is, yes, you'll end up with a lift, you'll end up with an implant, but this flattening will give you a very flattened breast. Even if we're using a high profile implant, remember a profile of the implant tells you how much projection you're getting. It doesn't mean you have fullness up here. You will have fullness here in a normal way, but you're not. A high profile doesn't mean you're going to have fullness here. That's a misconception. One final point I'll leave you with. because I've heard this so many times over my career where patients will come in and they'll have droop and they'll say, yeah, I know I need a lift, but I really I don't want to lift. I don't want the scar. I don't want to go through that. Just do an augmentation. Well, if you do that, which I would never do, you end up with a complete disaster, because what happens is the implant does not lift the breast. That's a really important point to understand, that an implant doesn't lift the breast. And people will come in frequently and say, oh yeah, I just want some implants, and they go like this. Well, the implant doesn't do that. The implant simply makes your breast larger. It gives you better cleavage, it gives you more volume, it gives you better fullness in the upper pole. The implant is remarkable, does a lot of wonderful things to the shape of your breast. But if you have a lot of droop, it's not going to lift your breast, and all that will happen is you'll get a dissociation between your breast, where the implant actually is going in, and then your breast will be drooping over. The bottom line is, and I tell patients this, if you need a lift, you need a lift. There's no way to get around that. So that's the difference between a concentric mastopexy and a circumvertical mastopexy. The vertical line gives us more power, and the more droop you have, the more likely you're going to end up with this pattern. So we can do all of those wonderful things to get a really nice conical shape to your breast, compared to potentially getting a flattened breast if we're asking too much of the concentric. And that's the basics of what we do when we're doing a lift and an implant. Whew. What was that, 10 minutes?
Yep.